So treatment for someone who has polycythemia focuses on the fact that we need to actually reduce the blood volume, reduce the thickness of the blood, and decrease the bone marrow activity. Mainstay is the phlebotomy, and that's just as it sounds. We draw off approximately 300 to 500 ml of blood until we get the hematocrit essentially at 45 to 48%, and then we do this as needed. The issue with phlebotomy is you're throwing away everything, and these patients typically become anemic, as where plasmapheresis can actually separate cells. And so we can focus more on getting rid of what we need to, such as the red blood cells, and return everything else to the patient. Obviously, this is more complicated and more costly and more time consuming. There are certain drugs now, myelosuppressive drugs, that can actually be utilized to decrease bone marrow activity, but then there are multiple side effects to these particular types of drugs, such as low white blood cell counts, placing the patient at risk for infection. And then allopurinol does not actually decrease red blood cell production, but a lot of times these individuals can end up with gout attacks, and so it can be used to reduce the number of gouty attacks. One of the unfortunate side effects of having polycythemia. And we have to focus on the signs and symptoms that the patients experience and help treat those. Paxil or low-dose aspirin can actually decrease potential coagulopathy issues, but also can decrease the burning pain in the extremities. We promote hydration therapy. This also reduces the blood's viscosity, but it also helps to neutralize the urine and prevent stones. And then if someone has splenomegaly, it is possible that if need to, they could take the spleen out, but more likely just rest periods and small frequent meals. Rest periods and small frequent meals. And remember, leukopenia would be from the fact that they had immunosuppressant drugs that suppressed bone marrow production. Nursing care, we want to make sure that the therapy is working, so we're going to monitor CBCs, looking at the red blood cell count, the hemoglobin, and the hematocrit. Do careful I's and O's. Monitor for any bleeding, especially if they're on a low-dose aspirin. Watch for any type of clots. Monitor for thrombosis, any kind of joint issues. Prevent the nausea and vomiting. Assess for abdominal and neurological changes, and educate the patient as to why they're having the therapy that they're having. These are just a few of the potential nursing diagnoses. With the increased viscosity of the blood, you could have ineffective tissue perfusion. So once again, you want to make sure that you're monitoring all the extremities, making sure that they have adequate perfusion, making sure that there's no clot formation, teaching the patient the signs and symptoms of decreased tissue perfusion, making sure that they understand the nutritional requirements, increasing iron in their diet because they're having phlebotomy. Typically, phlebotomy, after you get your hematocrit to where you need it to be, needs to be done every 2 to 3 months. And the disturbed sensory perception could be visual at first, until you get the hematocrit corrected. There's actually visual disturbances. Okay, guys, I just wanted to end up a couple things. I don't think I mentioned on the vitamin B12 injections that have to be done for life that there is also now a nasal form of vitamin B12 that a patient can take. And also there is a quiz. Has 10 questions that I posted online. So the quiz, 10 questions, and let's see, when should we make the quiz due? We need to make sure that you watch this and read this before your actual test. And so exam 3 is 10/6. So by 10/6, You need to bring in the completed quiz on the anemias. Thanks, that's it.